Let's talk about tooth extraction and immediate placement of small diameter implants with bone grafting and platelet-rich fibrin. This is a wonderful woman, grandmother, and obviously something in her system is missing to have this degree of periodontal disease at a relatively young age. She's in her 50s. So in those, I'm just showing the before and after. We're not going to go through all of this today. We're just going to show implant placement. And in a future video, we'll show the steps to get to this end. But you can see just severe periodontal disease. In cases like this where you have severe bone loss, and especially if it's at a relatively young age, in this case, the woman's in her 50s, she's missing something. Her system is missing something. There are nutrients, vitamins, minerals that she's missing unless she has systemic disease. And so you want to be sure to have that checked out prior to dental treatment if somebody has this type of bone loss, and have their physician do a blood test and just be sure that they don't have something of consequence systemically going on. But if they don't, then I want to be sure to place her on supplements to replace those things that she's missing, like 2,000 milligrams of vitamin C, vitamin D, coenzyme Q10, calcium with magnesium in women, and we'll list those later in this video. So standard of care when you're placing implants is one should take a pantograph and lateral ceph or a cone beam. Before I start these procedures, I list on a marker board where I should be at certain times. Many of the procedures we're doing are all day, and once you're into it, you want to be sure that you're staying on track so you don't run out of time. So I know that by 11 o'clock I should have extracted all the upper and lower teeth and completed alveoplasty. And we begin at 8 o'clock in the morning. So 8, 9, 10, 11, 3 hours later, I should have extracted all the teeth and performed alveoplasty. By 11:30, I should have drawn blood for platelet-rich fibrin. By 12:30, I should have placed the implants in the upper and lower arches. By 1:30, have completed the bone grafting and membrane placement. By 2, suture and deliver the upper immediate denture by 2:30. Now in these cases, the only denture the patient is going to be wearing for 3 months is the upper denture. No lower denture, because there's nothing to anchor it to. And patients will panic and think, oh my gosh, I can't get by with just an upper denture for 3 months. They can and they do, and no one will even know that they don't have lower teeth in place. So only an upper denture for the first 3 months. We'll talk about that more as the video progresses. So I know I'm going to finish about 2:30. Now, in those cases that are that long, you want to take a little break around 11 or 12 and give the patient something like a part of a milkshake. Especially if they're sedated, they may have had nothing to eat or drink since midnight the night before, and you don't want them to pass out from hunger. So if you're going past 12 o'clock the next day, take a little break, give them part of a milkshake just to get their blood sugar and energy back up. So I'm extracting the teeth. Now, it's not a bad idea to have a cleaning prior to extraction of the teeth. I did that on a patient just about like this the other day. Whenever you are extracting teeth or cleaning and there's lots of calculus on the teeth, be sure you pre-medicate the patient with antibiotics. And in this case, she was pre-medicated with 2,000 milligrams of Keflex an hour ahead of time, and then she continued the Keflex 500 milligrams 3 times a day for 10 days. We'll talk more about that. Amoxicillin is another very good antibiotic. 2,000 milligrams of amoxicillin pre-medication is good. And then again, 500 milligrams 3 times a day for 10 days. Now, these teeth are relatively easy to extract. If you have a patient that has decay but not periodontal disease and you're extracting for decay, especially a larger man, those extractions can be really difficult. These were not that hard, but it's not, it's not always this easy. One of the things I'm trying to do as I extract these teeth is remove them straight down or straight up and not go side to side, because I want to preserve the buccal plate. So I'm trying to extract the teeth straight down by unscrewing them, just wiggling like this, rather than going to the buccal, because it's very important that you try to preserve that buccal plate if you can. Do you think of how much healthier this patient will be? Can you imagine her body having to fight off the infection from all that bacteria and the bacteremia, and just, it's bound to give her, and patients report this, that they just feel like they've got more energy getting rid of all that bacteria. To deal with these kind of cases, you've got to be able to deal with the mess and have a vision of where it's going. So my thoughts are, when I take these teeth out, I know I'm going to have excess tissue. I'm going to remove some of that tissue, but I want to maintain the attached keratinized gingiva. You don't want to cut all the keratinized tissue off and only have non-keratinized, non-attached gingiva remaining. You know you're going to have to do an alveoplasty or recontour the bone. So the key to getting to the end of these cases is move forward with that. Don't mess around with it. Get in there and go, or you'll be here forever. So I'm cutting this excess tissue just from here to here, and I'm going to remove that with a rongeur. But don't mess around with this part. Get going, or it'll take too long. You'll never get through. Now, there could be those cases, especially if the extractions were going to be very difficult, that I would only do one arch at a time. Take out the teeth, alveoplasty, place the small diameter implants, bone graft, platelet-rich fibrin, collagen membrane, and then upper immediate denture. And I might just do that the first time, because taking out the teeth when there's no periodontal disease can be very difficult. And a lot of times you have to section the teeth, and it just takes time. These teeth were easy to extract. I'm just rinsing off the bacteria. I'm removing all that tissue. Now in this, I don't like to reflect the flap any further apically than I have to, but in this case, I've got to do a significant alveoplasty. Now here's something to think about, because we're always trying to conserve bone. I don't know if you've had anything to do with all-on-4, but if you watch surgeons with all-on-4, they always remove vertical bone to make room for the prostheses. If you extract teeth and you don't remove any vertical bone, you're not going to have enough room for your denture in a small diameter implant or implant supported denture case. So it's very important that you remove some of the bone so you have room for the housings and your denture. How do I know that? I've made that mistake early on with a couple of cases and had to go back and remove tissue, move bone. So be sure you want to remove some of this bone unless there's a lot of bone loss prior to the extractions. So I'd like to keep the flap, the apical aspect of the flap, in attached gingiva. I'm not able to do that with all of this flap. Now sometimes if you're covering a lot of bone graft material, it's actually advantageous to go ahead and reflect into the unattached non-keratinized gingiva, because you can pull the flap. It's like it's a spring or something that you can pull it, whereas if it's in attached gingiva, it won't pull. It just folds. These rongeurs, you want to be sure you don't have any sharp edges. But once you get it in your mind that it's actually optimal and desired to remove some vertical bone height, it makes it a lot easier. You don't worry about that. This is just a large bone file, smoothing everything out, so everything is nice and round with no jagged edges. I'm checking my sockets with the spoon to be sure I've curated out all of the granulation tissue. Now, something to be thinking about if you're watching this video, one of the reasons that I often like to place the implants at the time of extraction is you know exactly pretty much where the implant's going to go. The other thing is there's very dense cortical bone at the apex of the socket. And if the bone heals, then sometimes you lose that. And so I like to engage that cortical bone at the apex of the sockets immediately following tooth, if you place them immediately following tooth extraction. They're just curating the sockets to remove any granulation tissue, or checking to be sure there's not any in the sockets. So many of you will choose to only do one arch at a time, because it takes a lot of hand strength and a lot of endurance to do all of this in one appointment. Now I'm just rinsing everything thoroughly with Perigard, which is a chlorhexidine rinse. And how much do you use? I'll use probably 3 or 4 syringes, Scutan syringes of Perigard. Just cleaning it out. Now I'm going to draw blood for platelet-rich fibrin. And you'll remember that platelet-rich fibrin does 2 main things. Number 1, it forms a matrix for healing. And number 2, it's full of growth factor. So everything heals faster and better. This is a cold spray, so the patient doesn't feel the needle. Now these vials have a negative pressure, and they draw the blood into the vial with that negative pressure. So how many vials will I draw? Normally anywhere from 2 to 6. I don't think I've ever drawn more than 6. You want to be conscious of your time, because you don't want to leave the tourniquet on the arm for a long period of time. Probably I wouldn't want to leave it on more than a couple of minutes. I don't know if that's the exact time, but you don't want to just leave it on and not pay any attention to that. You might want to set a timer, but after a couple of minutes, I would remove the tourniquet, because you don't want to have damage to the arm. I actually had an implant placed myself on this upper left cuspid tooth, and the surgeon, following tooth extraction, placed platelet-rich fibrin in the socket, and I was amazed when he showed me what the healed alveolar process looked like after 3 months. It was very dense and perfectly healed, so this stuff really works. Then we're going to centrifuge it. You're going to centrifuge it 8 minutes, and oftentimes you've got to centrifuge it again. 8 minutes is not enough to form the clot, so if you take it out and the clot's not formed, centrifuge it again. Pilot drill, and I know I'm going to be using either 15 or 18 millimeter implants. Now, where are you drilling the pilot hole? I want to drill it in the socket with the pilot drill toward the palate. the palatal part of the socket, because I want my implant to be in this line and not this line sticking out of the denture. So I want to stay toward the palatal side of the socket when I'm drilling my pilot hole. Then I've engaged that dense cortical bone at the apical part of the socket. You like to engage cortical bone with the apical part of the implant whenever possible. And I'm using 2.5 millimeter small diameter implants, and I believe these were 15 or 18 millimeters. First the finger screw, now the winged wrench. Sometimes the winged wrench is adequate, other times you use the ratchet wrench for the final placement. Now I'm screwing this in until all the threads are below the height of the alveolar process at some point. Now these threads will not be apical to the bone on the facial side, but these threads on the palatal and the interproximal areas are all under the bone. So I know I'm going to graft this part. Now you don't want to place the implant in so that the threads are apical to the facial bone if it is apical to the palatal bone. Because if this bone is lower than this bone, or in this case higher than this bone, you don't want to put the threads, you don't want to use this as your guide. You want to place the threads under the most coronal bone, at or just a little bit under the most coronal bone, which in this case is the interproximal and the palatal bone. And then you want the implant to be going through the apex of the socket, but toward the palatal side of the socket. And then the orientation is correct in the denture. If you put this implant in like this, the implant is going to be hard to make an aesthetic denture because the implant is going to have a tendency to stick out the facial side of the denture. You can see this much of the implant threads were exposed, so this is going to be bone grafted. Just light pressure, 1200 RPMs. So in this case, I know I'm going to have quite a bit of bone graft, platelet-rich fibrin, possibly in collagen membrane. So you want to reflect all the way to the unattached, non-keratinized gingiva so you can pull it up over the bone graft. Again, 2.5 millimeter implants, either 15 or 18 millimeters. So what are your, I'm always checking with the large mouth mirror, your areas to be concerned with on the maxilla are the sinus and the nasal orifice. Now this is platelet-rich fibrin. Though the patient's blood's been spun down, you see this nice clot. And you're only using the yellow part. You're not using the red part or the bloody part. And like we discussed, this platelet-rich fibrin creates a fibrin matrix and it's rich in growth factor. So the healing is much faster and more efficient. You put them on the tray and you see the holes in the tray, because when we put the plate on top of the PRF, it's going to squeeze out the serum into the bottom of the tray, and we'll use that to mix with the bone graft material, because it also is full of growth factor. So remember, when you spin this down the first time for 8 minutes, the yellow part or the yellow clotted part may not have formed. Don't panic. Just spin it again for 8 minutes, and we've never had it not form the second time. Again, pilot drill, you can see I'm toward the palate through the apex, so that's the perfect angle of these small diameter implants. It really helps take some of the guesswork out of, or judgment in placing the implants, because you just put them right back in the sockets if the sockets are where you want the implants to be. I'm checking with the large mirror to be sure my angulation is correct. This is the winged wrench. If you don't have enough vertical dimension, you can't use the winged wrench, so you'd go straight from the finger wrench to the ratchet wrench. I like these Park Dental implants, but I don't like that long white part on the top. It's a little too long, and if you don't have a lot of vertical space, sometimes that bumps the opposing arch. I'd like that white carrier to be about half that large, and you can go ahead and cut that off if you want to and make it about half that large. Sometimes I'll do that. And I have no connection to, so I have no connection to Park Dental or any of the other companies referenced in these videos. So I'm drawing up the serum from the platelet-rich fibrin clots, and this is on the bottom of the tray, and I'm squirting it into the vial and then placing my bioos cancellous bone and mixing it with that. Now you can cut up the platelet-rich fibrin and mix it with the bioos. What I'm doing in this case is placing just the bioos cancellous particles, and they've got a small and a large. These are the small ones, and then I'm going to place the platelet-rich fibrin membranes over this. You want to try not to touch the implants with these other instruments that are dissimilar metals, or you can create a galvanic situation that could affect the osseointegration of the implant. I've never had that happen, but so says the literature. You can place bone graft material all the way back into the posterior teeth. That's not a problem. I'm not as worried about the posterior part of the mouth because those defects were so large as I am about this part, because this is where my implants are and this is where the stability of the denture will come from. If I was bone grafting the sockets back here, I would use the larger particle size of the bioos cancellous bone graft material. You can see I can pull this flap. Now these are the platelet-rich fibrin membranes after they've been flattened in the tray. You see how they've been flattened when you set the plate on top of them in the tray, and it also expresses the serum through the holes, and that's what we drew up and mixed with the bone graft cancellous particles. There's a line on the tray that you can use to cut the platelet-rich fibrin membranes if you need to size them, if you're not using the whole piece. This is a resorbable collagen membrane. I don't have any tie to Dynomatrix, but the main thing, one of the main things with a resorbable collagen membrane is you want it to relax. You don't want it to be stiff. You don't want it to be like a starched shirt that the edges pop up. I want it to lay down on the bone graft material just like a blanket. And this is a very good one. Just cutting the corners off makes it easier to place. You soak it in sterile saline for 5, 10, 15 minutes. If I know I'm going to use a collagen matrix, I ask my assistant to go ahead and put the matrix material in the sterile saline while we're doing the rest of the work, because it doesn't hurt if you soak it for 30 minutes or an hour. But I'd say at least 5 minutes. And I want to be sure that the apical part of this resorbable collagen membrane is past the bone graft. I want all the bone graft to be covered. I'm placing this apical to the bone graft. And just make some cuts right here so that the graft material, the membrane will lay down on each side of the implants. That's easier for me than making holes for the implant heads. Amazing how that platelet-rich fibrin is already adhered to the bone graft material. It's not moving. Cutting that little slot, not all the way through, but just where it'll go on each side of that implant head. Got an implant right there, so we're doing the same thing. Once you've sutured this, you're going to be completely confused if you don't keep your orientation point straight. The key is the threads and the bone. The tissue is of no consequence. The tissue will cover the implants and just the heads will be sticking out if you place the implants at the same time you extract the teeth. The thing that saves you, that makes this all work out, is if you're careful about where the threads on the implant are screwed into the bone. Then you want all the threads to be covered on the most coronal part of the bone. Don't keep screwing it in until the threads are under the bone that's apical. If it's lower or higher than the highest bone or lowest bone, you don't want to worry about that. You're going to bone graft it. So if you get the bone and the threads right, the rest of this will turn out beautifully. The other thing that you want to think about when you're removing bone, this is a mistake that most people make, I made it, is this alveolar ridge can look like a roller coaster. You'd rather not have that happen. You'd rather it be pretty symmetrical. So if you've got, it's a judgment thing, but you'd like the coronal part of the ridge to be symmetrical so your implants don't go like this. Now here we are sutured, and when you looked at that, you'd go, oh my gosh, I've made a huge mistake. This can't work out. It will work out if you've got the bone and the threads right. All that will heal. It's like little plants budding up in the spring as that tissue heals. Now, do you have to have primary closure all the way? No. You want it close, but you don't want to stretch that tissue. You don't want to blanch it. And because you've got the platelet-rich fibrin and the collagen matrix on top of the bone graft, this is adequate. It doesn't have to, primary closure is always great, but you don't have to have primary closure. Now we're putting adhesive on our immediate upper denture, and then we'll put soft liner in the denture. And the patient's going to wear this for 3 to 4 months while the implants are osseointegrating and we're fabricating the final dentures after 3 months of healing. What's another reason that you might want to place the implants at the time of extraction if you can do it predictably? Why not just extract the teeth, bone graft it, and wait 3 months and then place the implants? Well, especially in the maxilla, one should wait at least 3 months for osseointegration of the implants before final denture placement. So if you're placing implants in the maxilla and you extract the teeth and then you wait 3 months and then you place the implants, they've got to wait another 3 months before you can fabricate the dentures. So they've waited 6 to 8 months with only an upper denture. So if you can place them predictably at the time of extraction, the patient only has to wait for 3 months of osseointegration before you can fabricate the final denture. It's easier if you wait until the bone has healed for 3 months and then come back and place the implants. My feeling is you haven't lost anything if you go ahead and place them at the time of extraction. Because worst case, if an implant was not, where it didn't grow out enough, the tissue didn't do what it was supposed to do, you could always place another implant in 3 months. Or you could unscrew one of the implants with your ratchet wrench. You can actually break the bone around the implant after 3 months. So you really haven't lost anything, and most of the time it's going to work out beautifully so the patient doesn't have to go through a second surgical procedure, and you can get on with the fabrication of the dentures sooner. I'm placing Vaseline on the facial and the palatal of the denture so the soft liner won't adhere to that part of the denture. Any soft liner is good. Now I'm placing shim stock either on the sutured flaps, or you can place the shim stock on the soft liner in the denture. And that's just to keep the soft liner from going into those sockets through the suture. And it also keeps them from sticking, keeps it from sticking to the suture. So now we're doing the same thing on the lower. We've already extracted the teeth, and I'm removing this bit of tissue right here because I know after my alveoplasty I will have lost some bone. So I'll have a lot of excess tissue, but I don't want to remove it into the unattached, non-keratinized gingiva. Now, if you didn't have enough keratinized attached gingiva, that's a case, as we've talked about in other videos, and I've demonstrated in other videos, that you might need to gingival graft with either palatal tissue or something like periderm. And we have videos on that. Trying to be very careful not to tear the tissue. And you want a full thickness flap. And in this case, we're going to extend the flap into the unattached, non-keratinized gingiva. Now, you don't want to reflect too far lingually. You would like to have attached gingiva, or that flap connected strongly to the alveolar crest on the lingual. You don't want to reflect way down, or it will, you could have some issues there. I'm removing the soft tissue tags. And then this is a coarse diamond, football diamond or egg-shaped diamond. Lots of water, light touch, and just continuing my alveoplasty, rounding out all the edges and removing some of that excess bone. Then coming back with the rongeers, doing the same thing, rounding the edges, and then this is a bone file. It's everything nice and round. And as I was saying, you'd like this final ridge to be symmetrical, or on the same horizontal plane. You don't want that ridge to go like that if you can help it. I've identified my middle nerve back here. And in this case, I've got plenty of room mesial to the middle nerve, so I'm going to go ahead and drill both these holes with the pilot drill. I'm just perforating the cortical plate at, if I'm in a socket, I'm going to perforate the cortical plate at the apex of the socket, because that implant will not screw through cortical bone. It will only bite and screw into trabecular or medullary bone. Once it hits cortical bone, it will embed, but it won't continue to screw. So you've got to drill through any cortical bone that may be engaged by the implant. In this case, I'm actually drilling to the depth of the implant to be sure that the cortical bone at the apex of the sockets does not stop the implant from screwing in. So these are actually 2.5 and 2.0 millimeter implants. If I'm screwing them into the socket, you've got a wider space and a larger ostectomy or void that you want to fill, and so the 2.5 may be the implant of choice. But in those cases, you've got to drill to depth because the 2.5 won't screw into undrilled bone. It's too large in the mandible. It's just too wide. If it is 2.5, I've even used my 2.2 millimeter diameter root form implant drill to drill to depth. Now, it only extends to 14 millimeters. That drill only goes to 14 millimeters. So if you've got an implant larger than 14, that could be a problem. But a 1.8 or a 2.0 or a 2.1 millimeter implant is very, very adequate in the mandible. The only reason I would use a larger one like a 2.5 or even a 2.9 in the mandible is if I extracted the teeth at the same appointment and I had a large void, say in a cuspid area, that I had a large void to fill, I'd rather use the larger implant, but you've got to drill all the way to depth prior to placement of the implant. See how these are toward the lingual of the sockets. That gives you the correct implant orientation. At this point, I use either the winged wrench or the ratchet wrench. Now, if you use the ratchet wrench, go slow. Don't burn the bone. Don't go like this. Go quarter turn, quarter turn, quarter turn. Same thing with this. Winged wrench, you only want to go a quarter turn at a time. You can see how sometimes this long white part hits the upper ridge. So I'd rather it be about half that long, or the white carrier part be about half that long. The other issue you sometimes have with the winged wrench is there's not enough vertical space here for the winged wrench. And in that case, you'd skip the winged wrench and go straight from the finger driver to the ratchet wrench because it doesn't take as much space as the wing wrench, vertical space, as the winged wrench does. The winged wrench is a little trickier too because it's hard to not have it wobble when you're changing fingers and doing all this. I find it easier many times to just put my finger on the top of the ratchet wrench and just screw it in. You don't have the wobble that you sometimes have with the winged wrench. So I screw this in until I can't screw it anymore. Then remove it, check with a large mirror to be sure my angles are right. The winged wrench would be easier if this bar was shorter. You know, what I'd like to see is a winged wrench that had a bar just long enough to engage the implant, because you never need all of this part. I'm checking occlusally. Remember, each implant can have a 30% divergent from the other implant, so it's not as, you don't have to be as precise as you do with root form implants. I'm squirting the PRF serum into the vial and then placing my biowash using the PRF serum as the wetting agent for the biowash cancellous bone graft material. And again, trying not to touch the implants with my dissimilar metals. Now I'm placing the PRF membranes. And once they've been flattened out, that's what you call them, a membrane. And it's very acceptable to use these alone without a collagen membrane on top of them. Remember, the whole idea of a membrane, in this case, it's for healing as well as blocking soft tissue from healing the sockets prior to the bone. Soft tissue heals faster or grows into voids faster than bone. So you use the collagen membrane and the PRF membranes to block that. And in addition, the PRF is full of growth factor and forms a matrix for bone healing following extraction. So see, I'm taking a big bite here. Don't take a little tiny bite or it'll pull through. Take a big bite, a big bite here and a big bite here. And don't worry about what it looks like after you have it sutured. The key is get the threads under the most coronal bone. Get the threads under the most coronal part of the alveolar process. I say that because if the bone slopes like this, the lingual part of the alveolar process will be higher than the sloping facial part of the alveolar process. So you only want to get the threads under the lingual part of the alveolar process, and we're going to bone graft the facial part that has exposed threads. So I'm not paying any attention to what the implants look like right here. All I'm doing is trying to approximate the tissue. Now the lower is always a trick because of the lip pull and the chin pull. People tend to pull this loose, and oftentimes you'll have to resuture that after a week or so because part of this will have pulled through. So I want to encourage the patient not to do this, not to move their lower lip any more than they have to. Okay, here we have the maxillary and the mandibular. You see how you just see the little heads of the balls. They look like little bald heads sticking up through the tissue, and that's just fine. What I'll generally do is just kind of push this tissue down so I can identify the little bald head on every implant. It's amazing how that heals. So I'm going to place Fixodent on the upper denture, only in the palatal part. Wet the palate. Wet the palate. Push that to place, and she will do fine with just a maxillary denture. At first I thought people would lose weight, but if you think about it, what are you gonna connect a lower denture to? You can't connect it to the implants, and there's really nothing to hold it in. I personally don't make lower dentures without implants just because they're so unsuccessful in my hands. It's so hard to make them stick, so it would really be difficult with the lower, like with the mandible post-surgery, to keep something in there, and it would be rubbing on the implants or in the tissue. So just bottom line is no lower denture for 3 months, only the maxillary, and the patient will do fantastic and they'll look great. So these are things that I want a patient that has severe periodontal disease to be taking. Vitamin C, D, A, and E. Calcium with magnesium if you're a woman. Now remember, you have to have magnesium for calcium to be absorbed. Zinc, CoQ10. The supplement should be vitamin D. The supplement should be taken daily by patients with periodontal disease. Also selenium, found in nuts and vegetables, grapefruit seed extract, cranberries and cranberry juice, and omega-3 fatty acids found in salmon and other fatty fish, and fish oil supplements are very good. So here are the implants in place, and you can see all the threads are under at least part of the bone. They're under the most coronal part of the bone. I want to be sure to make that point. The most coronal part of the bone, and you're going to bone graft the other part of the coronal part of the socket. So here's, this is after 3 months of healing, the maxilla and the mandible. That's just perfect. This is the final case. We're going to go through other videos discussing the other steps. There we have it. Every year I take 12 dentists at a time down to Mexico, 1, 2, 3, or 4 different times. And we go to a beautiful clinic in Puerto Vallarta and actually place implants in live patients. Again, in a beautiful clinic, cone beam radiograph, periapical radiographs, pantographs, assistant, highest level of sterility and cleanliness, and you have patients there with a real need. So you have instructors like me with each dentist, and you have 1 case in the morning and 1 case in the afternoon for 3 days. We go on a Wednesday and return on a Sunday. So Thursday, Friday, Saturday, you'll be placing implants in the morning and afternoon on 2 separate cases, and you'll be assisting your partner on their case in the morning and the afternoon. Plus, you've got the other 5 operatories, I guess, with dentists, and you can go back and forth and see what they're doing, because we have dental assistants who are actually graduate dentists in implantology. So it's a fantastic experience. I've found with any surgical procedure that I can teach the procedure to dentists, but they never institute it into their practice unless they've had the hands-on experience with live patients. It's a fantastic experience. If you would like to go or discuss the trip with our representatives, click the link in the description.
Thank you all so much for joining us this week on the Dental Minute. Make sure you go ahead and press the subscribe button right here and join us next week, because we will be talking about how to give a painless injection. Everybody needs to know how to do that. We'll see you next week.